Everyone, and welcome to the today's Facebook Live. In this chaos of Corona pandemic, there are a lot of things which are kind of non-pandemic related, which is causing problems and bringing children into the hospitals. One of the more important causes why children land up into our emergency rooms and ICUs are childhood injuries. Now, these are injuries happening in normal children because they are exploring their immediate surroundings. They have completely locked down into their indoor surroundings, not having an outlet to go out and burn out their energy. And because as more children are inbound nowadays, they are landing up with injuries like corrosive poisoning, falls, electrocutions, and having ingested certain other household poisons. So to discuss this issue today, we have with us Dr. Divya, who is our consultant pediatrics and pediatric emergency medicine. And welcome to the talk, Divya. And we have Dr. Dhiraj Balaji, who is a senior consultant pediatric surgery and who helps us with handling these children. And if there is any need for a surgical intervention, he's the man to go to. So that's setting the context for today's Facebook Live. And to start with you, Dr. Divya. So you have seen in emergency children coming with so many issues during this pandemic. So what kind of injuries do you routinely see in emergency room? Not talking only about the pandemic, but routinely, that is one of the reasons why children come to emergency very often. So what kind of injuries do you witness in the emergency room?
All over the world, childhood injuries are one of the common causes for emergency department visits, and our hospital and our country is not an exception. We see a variety of injuries ranging from small cuts and bruises due to falls in the home, while playing, to severe injuries like head injury from fall from the stairs or automobile injuries. And we see a panorama of injuries. And as you previously mentioned, a lot of household poisonings like ingestion of drugs, which the elders use, ingestion of corrosives, especially cosmetics, nail polish removers, toilet cleaners, kerosene. Of course, kerosene has gone a little bit out of the vogue, but paint thinners are now more common, which has a common ingredient as a solvent. And this all-out ingestion, these are all very quite common. And foreign body injections, especially less than 3-year-old children, are very curious. They mouth all these small objects which they see. So foreign bodies injection is also very commonly seen in our ER.
So generally now, world over, what also has been described is that childhood accident is the fourth commonest cause of death world over, and that is also causing severe amount of disability. For every child who dies, there are at least 5 children who have a limb-threatening injury and have to be kind of need a prolonged rehabilitation as such. And data-wise, the data is actually shocking. So world over, almost 2,000 children die every single day. That would mean every single minute, one normal child dies on this planet because of a freak accident in a normal child. And Indian data also, as you must know, the recent data came out from the WHO Collaboration Center for Injury Prevalence, and that is suggesting almost 165 children die every single day in India because of an injury-related problem. So when you're in the emergency and when a call comes to you saying, okay, somebody has got hurt, you must be asking how old is the child. So what exactly is the age kind of prevalence of these injuries? In which age is it very common?
So the different type of injuries are common in different age groups. For example, household accidents like falling from the cot or falling from the stairs. These are common in younger children, less than 5 years. And mostly children who have not become very stable while climbing things and while running, especially with the slippery floor things nowadays. Other things like sporting injuries are more common at above 6 years. And the other rare sporting injuries are with extreme sports are seen in teenagers. Especially nowadays, teenagers go for skating, for ice snowing and all those things. Road traffic accidents have 2 peaks. One peak is in a very young age group, less than 3 years old, and the other peak is at 18 years. So 18 years is the time when they start exploring their own vehicle. So that time it is more common. And the younger age children, when they are involved in a road traffic accident, the mortality is the highest for the smallest child when they are involved in a road traffic accident. And other things like drowning, especially in the swimming pool, or partial drowning in your bathtub, or in large vessels which have water or buckets. These are seen in small children, especially less than 3 years, where they can just fall into the bucket. Other sporting injuries like or rather electrical injuries are seen in mostly all age groups but less than 5 years old.
So you are saying that the toddlers are definitely a very high risk population for childhood injuries because they become mobile by 1 year of age.
Yes.
They are more exploratory. They are more curious. What we say about children is their curiosity is not matched by their understand ability and understand the dangers that are there surrounding them, and that exploratory nature puts them at risk for these kind of common household injuries. There are also certain other physical, mental, and psychological factors which we describe when we are talking about injuries. Like in small infants, they are top heavy, so when they are bending down, they immediately
just
fall because they topple and fall, and the head usually hits the ground first. And their hand-mouth coordination develops by 9 months, so their grasp and the hand-mouth coordination is very good. So whatever they find, they put it in the mouth immediately, and that sometimes results in ingestion of things like button battery, which Dr. Dhiraj has to extract in his operation theatre. And also, they have very weak legs, so they can't wriggle out of danger so easily. So these are kind of the infancy, 1 to 5 years, I would say, may be the kind of at-risk period for all these accidents. And after that, children start spending a lot of time outdoors, inside the school. And as you rightly said, I think teenage period is where the injury profile is slightly different, because those children are kind of physically reaching their peak, but they're emotionally very labile. They try to show off. A lot of unsafe practices come up, and vehicular accidents, as you said, they're exploring their vehicles, they're going for a long drive, and not only they put themselves at risk, but sometimes innocent bystanders also can be a victim for these kind of injuries.
So this road traffic injuries, if you see, it is one thing is the children traveling in the vehicle, and the other thing is pedestrians also.
Yeah.
These children nowadays, because many places they don't have place to play, they play on the road. So pedestrian injuries are also very common. One thing what we saw is that when the car takes reverse, so that time, and when the school bus or van drops the child, that time also the child can accidentally get run over by the car or van.
Yeah, that's a very important point that you brought about, because children usually their peripheral vision is very narrow, so they don't have idea what is coming from each side. And also for people who use cars on a regular basis, we tell that kind of go around the car once before you get inside the car, because somebody may be playing hide and seek, sitting in front of the car or back of the car. And nowadays cars have reverse parking cameras, but even the older cars where the rear view mirrors cannot pick up a child who is hiding behind the car.
So there is a blind spot in your reverse camera also. What is just below your car, you cannot see. Whether it is the mirror or the reverse camera, you won't be able to see. So that should be taken into account.
So Dr. Dhiraj, I want to get you in here. As a pediatric surgeon, you may be getting a lot of calls for injuries and trauma. For pediatric trauma, as such, why children need to be observed in hospital? Because parents panic suddenly. Why is it that my child needs to be in hospital for 1 day? What is it, doctor, that you're anticipating? Or so what are the reasons why we always observe? We always tell the parents that let the child stay in the hospital for making out what else is happening with the child.
Exactly. We get definitely a lot of calls of injuries and wounds in ER. There are different modes of injury what we see in pediatric age group. It could be high impact injuries, low impact injuries. It could be witnessed or unwitnessed injuries. This is usually witnessed and low impact injuries, like falling from a table or a chair or just tripped over while walking. Those injuries which where the cut is there, they can be sutured and bruised, and a small bruise can be dressed, wound can be dressed, and after evaluation can be discharged. But high impact injuries, like when the child is going on a cycle, tripped over a cycle, and the cycle bar has hit the abdomen, or baby has fallen from a greater height, or if there is a blunt abdomen, there is a penetrating injury, or when we see there is a bruise on abdomen wall or a chest, we expect there could be some sinister going on inside the abdomen or a chest. Like, as a pediatric surgeon, I would say 124 hours observation, because there could be pancreatic injuries which goes unseen initial evaluation or assessment. It could appear definitely normal, and then slowly over a period of time they start developing symptoms and abdominal distension occurs. So splenic injuries, pancreatic injuries, chest injuries like air collection in the chest cavity causing respiratory distress, it can start developing over a period of time. If it's neglected, there could be catastrophe events occurring. So then we may not have any time. So better 24 hours observation, then second evaluation, if everything's fine, then baby can be sent home.
Yeah, so what you're saying essentially is that children have injuries which are more hidden than apparent. So, and then even we know that, structurally the rib cage of the child is not developed enough to protect our intra-abdominal organs. And even the pelvis is not developed, the bladder and all these are extra pelvic organs. So any injury impact onto the chest and the abdomen needs to be observed, because initially there may be a blood clot which arrests the bleeding, but later on there may be a slow bleeding which may manifest.
Even in mesenteric tears, what we see, slowly bleeding started occur later, and then blood in the abdominal cavity start presenting late. Yeah. We have seen after 6 to 7 hours after evaluation also.
So it's very critical that parents understand that injuries, when it happens in children, even if the child has come walking into the emergency, it is important that they understand the significance of having to observe. And the second evaluation, as you told, and only once the clearance happens from you, we are more comfortable. But still, sometimes we will have to give the danger signs education to the parents before we discharge them home. So again, coming back to you, Dr. Divya. Now, if you are yourself a pediatrician, an ER physician, and also a mother of 2 naughty boys. So now, if you have to go outside into the community and tell mothers about child safety, what will be your advice to all these mothers?
Okay. So the concept of child-proofing your house, it is still in the infancy in our country. But most of the Western countries, when they plan the child itself, the house or the flat or whatever it is child-proof. So at least we cannot change our house in our scenario. So some child-proofing and child safety measures can be done. For example, we just visualize our house. So first, when we enter the door, the locks, it is better to be at a little higher point so that the child doesn't reach it. And when the door goes back, it is better to have a hold so that the door doesn't bang at the back. And the flooring, nowadays the tiles and all are very slippery, especially the toddlers, as you were telling, their head is heavy and they can topple off. So it is better to have carpeting for at least the walking areas. A thick carpet which doesn't move so that the child has a grip when the child is walking. Other thing is switches, electrical switches. So it is better to have switches at a higher point, or at least the plugins should be locked when not in use. So that the children, what they usually do is that pencils and small sticks, they will keep poking into the electrical sockets. So that can be avoided. Next, if you see the sofas and the chairs, it is very difficult to restrain your child from climbing the sofa or the chair. So it is better to have little lower level sofas and chairs, and especially in the dining table, when you make the child sit, it is better to use a proper child seat which has a harness to hold the child. Next is the kitchen. The kitchen, if you just look at the modern kitchen, it has so many dangerous things, hot soups, hot things, knives, and even the small things like big vessels which have liquids or water. So that can also pose danger to the child. So it is best to not encourage the child to play in the kitchen. Yeah. So our mothers, what do? They will be cooking and the child will be playing in the kitchen. So that if it can be avoided, it will be very good. So avoid playing, allowing the child to play in the kitchen. And when you keep on the counter, keep it little behind so that the child cannot reach it and just pull the hot liquids. We see lot of scars and burns when the child pours a hot sambar or rasam onto the child. Next is the stove. So it is better that the stove is also little behind. All the lighters, matchboxes, they are little away from the child. And of course, your knives and your scissors and your cutlery, they will have to be really out of reach for your child. The other dangerous place is your bathroom, especially the toilets which have Western toilet which always have water. The child can just fall into the Western toilet, or tubs where the water is not drained, buckets which have water. These are all places where the child can get partially drowned, and partial drowning is enough to kill the child. You don't have to have 3 feet or 4 feet water to drown a child. Next is toiletries. It is better to keep all your chemicals, for example, your cosmetic chemicals like your makeup removers and all those things at a cabinet which is high and it is locked. This holds good for all your all out, your toilet cleaners, your liquid soaps. These cleaners are usually they look like Coca-Cola, or some of your phenyl groups look like milk. So it is very tempting for the child to just take a sip. And one sip is actually enough to really kill the child. So these things should be very safely kept in a cabinet above. And if you have staircases inside your house, you should have a small child door and a lock. These are the things which you can definitely do before your child is even come into your house.
Yeah. So you brought out those points beautifully. I think what parents need to understand is that a children's skin is almost 30 to 40% thinner than an adult skin.
Yes.
So it cuts easily, it bruises easily, it burns easily.
Yes.
So you spoke about in the drawing room itself, because the low laying switches is basically a Western concept with wall to wall carpets. So even a crawling child will get access to that. And even a 9-month-old child, the first thing we teach them is switch on, switch off, and light on and fan on. So they know what is switch on and switch off. So they put their fingers, and sometimes they can get electrocuted injuries. Also, the Indian kitchens are so much of aroma and sound and smell. And imagine a toddler 3-year-old who is watching an egg turn into an omelette. For that child, it is like magic. So it wants to put his hand inside and feel it and things like that. So we get a lot of, as I said, burn injuries and cut injuries from the kitchen. So simple things like turning the handle of the tea kettle towards the wall itself can prevent a child from grabbing and pulling and preventing these cut injuries. Bathroom accidents, again, you told that one common thing which I tell mothers is that whatever is needed for the bath, you should take at one time. Never leave the child alone in the bathroom and come out to pick up some things or answer a phone call or doorbell and things like that. Because in that 1-2 minutes, what happens? Baby slips, falls, and then can get injured. So those are a few things. So essentially, you brought out the whole concept of passive supervision very beautifully. That we have to baby-proof our home in such a way that if our baby is in another room, we know that there is nothing dangerous in that room which the child can get hurt with. And about the concept of keeping all the dangerous household chemicals out of reach, or even I would say out of sight, so that they don't get attracted. Because once you keep out of reach on the fridge or something like that, the moment child is able to put a stool and climb up, many times they do that. They put out the medicines which grandmother is eating and they keep on swallowing one by one. So we see so many accidents with children coming with swallowed BP medicines, sugar medicines, seizure medicines, and all those things. So Dr. Dhiraj, coming to you as such, when these children come to emergency and then we see the child and we think that it needs to go for a surgical intervention, maybe it is a cut and a bruise which is very severe, maybe it is some lung contusion or say some head injury, and when we suddenly tell a child who was playing half an hour back now is in the emergency, now it needs to go to theatre. Because many times we have had severe fall with blunt trauma abdomen, which needs to go to theatre immediately. And parents are very anxious as such, why my child needs to go to a theatre, should I wait? So what are the support systems which are there in place in our hospital to say that, look, your child will be safe, and in case there are any untoward complications by the incident per se or by the surgical intervention, how can we overcome those issues as such? So what is your take on that?
Yeah, with child with injury, as you said, any injury, I have a clinical diagnosis, and after that I decide to go for surgery. Before that, I would like to be doubly sure of my diagnosis. And in this hospital, we have a complete range of imaging modalities like high resolution ultrasonography, CT scan, MRI available 24/7, and radiologist team is there to assist my diagnosis and to give any extra information over that. So once I confirm my diagnosis and once I confirm that and I think of going for surgery, then I have a dedicated pediatric anesthesia team available 24/7 for our children to be operated. They look after from the smallest surgery to the most complex surgeries they are able to handle. And post-operatively, as a surgeon, I need a best post-operative care. So post-operative, we have a state-of-art pediatric ICU team with ICU facility headed by Dr. Chetan itself. And basically, in complex cases and polytrauma cases, we definitely require ventilator support, which is definitely comfortably handled by a pediatric ICU team. And doing all this, we give the best outcome for the child. That is what is our take in this.
So like I told, some of the injuries may be time critical, which may not give us time. We need to go into the theater middle of the night or off hours. And even if the support system is strong enough and robust enough for us to look at that, it really gives a reassurance for the parents as such. And our experience together of working for last 3 years handling these injuries, we have never had a problem, even off hours of kind of confirming the diagnosis with imaging, taking help of our anesthesia colleagues to address a small child, and also the post-operative care so that everything seamlessly gets done and we are able to provide a safe clinical environment.
Excellent outcome to the child.
Yeah, and give an excellent outcome without any comorbidities and long-term complications for the child as such. So, Dr. Divya, coming back to again a kind of community aspect as such, a lot of things have changed in our own lifestyle. I know how we were growing is completely different from how our children are growing. So, what are the current changes in the society, in the lifestyle that put the children of today into a greater risk?
There are many things as we advance towards the so-called westernization. There are a lot of setbacks. For example, our roads are double, triple, 4 times more congested. There is no pedestrian walkway, and most of the children in the cities, apart from the children who are in special apartments which have play areas, they don't have play area. So they play on the roads, especially roads which have traffic also. So that is a major hazard. Other thing is our playgrounds. Even the best of the playground is a mix. Small children are playing in the seesaw and all those things. Bigger children are playing with cricket, football. So there is a mixture when the small children can be hit with the ball, or the children may run away because there is not enough surrounding compound. So play areas. Then the other important thing in the house is in the apartments, the balconies. Sadly, we keep hearing things when the child is fallen from the 18th floor, 14th floor from the balcony, when especially the mother is feeding and the child just jumps like that. So we do see, apart from suicides, we see unintentional fall of children from heights. And next is pool areas. So childhood pools should be really dedicated and with swimmers and with proofing, which even though it is there in our community, it is not as good enough to prevent accidents. The next area where the children can get hurt is all our household things, like the chemicals and all those things which we have told. So previously everybody had their toilet or bathroom way outside the house, so there was no mingling. Even the kitchen was a separate area. Usually the children or even the husbands don't enter the kitchen. So it was clear segregation of area. Nowadays the child is given the top priority. The child goes anywhere, everywhere, opens any cabinet. The child has no bounds. So this leads to more accidents and injuries to children.
So few, I think, structural changes you brought out very nicely, that our playgrounds are not safe enough. It is not confined enough. Children have to kind of make space to play and or use the same place which is being used by the traffic to play as such. Also because current day, I think one more focus area is that how distracted are today's parents. Everybody is on WhatsApp. You so call this generation a head-down generation. So parent is playing, child is playing, but parent is always on the WhatsApp. Even if the child is in the pool or child is in the park, the mother will sit in one corner and do WhatsApp. So there is nobody eyeballing the child as such. And one I think side effect of the breakdown of the joint family structure is that there are no elders in the family or other extended family who is going and looking after the child while mother is doing other work. So today's mother has to work professionally, take care of the baby, and also make sure that the injury prevention happens. So that is very, very tough, and we are so busy being, and our homes are full of these gadgets which distract us from the primary motive of keeping our children safe.
Especially when you have domestic help, they will not be as motivated as us. So they will either give the gadget or put the TV or put the child to sleep. Sometimes even with cough syrups or medications. So domestic helps. We even have a child who drank a liquid cleaner because the domestic help mistook it for something and gave it to the child. So such a sad state also exists now.
So I think the message is very clear that prevention of childhood injury is predominantly adults' responsibility.
Yes.
You cannot modify the behavior of the child because they are exploring their immediate surroundings. They don't have the insight as such. So we have to baby-proof our homes. At the same time, we have to take that responsibility that my child in this surrounding is not safe. So our antenna should be up. The sixth sense should actually see immediately. If you go to some public place, you scan the area, look, oh, my child should not go to that area, this area, and protect the child, hold the hands and be less distracted, especially when children are playing with in an unsafe area as such. So keep your phones away and things like that.
Being a parent is a lifetime commitment.
I agree, and we, because we see all these things in an emergency, as parents we also feel very scared as who's looking after our children when they are at home.
Yes, definitely.
So, Dr. Dhiraj, tell me, when something happens like this in the community, in the apartment, and things like that, we always reach out to the community to say, look, you need to reach a place where pediatricians are available 24 hours, when all the facilities that you told, imaging and pediatric anesthesia, pediatric ICU, it is important. Some of the injuries, as you told, low impact injuries, cuts, bruises, which can be immediately addressed.
So basically, witnessed injuries, low impact, can be addressed
in a local, smaller setup.
Non-witnessed and high impact injuries, yes, definitely.
So what are the life-threatening injuries which you would advise, say, in a 5 kilometer, 10 kilometer radius parents that you need to reach Aster ASAP?
Yeah, and more than life-threatening injuries, I would say life-threatening cases rather. It could be non-traumatic or traumatic life-threatening problems. Wherein first I would like to highlight non-traumatic. Basically, the child is playing, suddenly they have breathlessness. If they're eating, suddenly they go into breathlessness, or eating something, severe breathlessness occurs, or they choking or ingestion something, or they've fallen suddenly and they have abdominal pain has occurred. Then I would say we would suspect definitely a airway foreign body is there. So they have to reach our hospital as early as possible, because I would like to give some examples over that. And in airway foreign bodies, I would say there could be a rapid deterioration in the child, and even they can succumb also. So if they reach as early as possible, the message here would be that time is very crucial in such patients. And for example, I would give 3 patients there. The child had come from Andhra with sudden onset breathlessness. They had gone to different hospitals and was not properly diagnosed in another hospital. They came to us. It was in a very sick state and severely breathless. Then we had to stabilize the child. Baby was in a PICU for it was ventilated. Then on stabilized, then we investigated the child. CT scan was done. We found a big foreign body in the right airway. Then immediately a procedure was done. Emergency airway procedure was done. Removed the foreign body, and then post-operative ventilated. And then child survived and did well. The important message here is the time is very crucial, and they should go to a place where multidisciplinary people are available, focused personnel who are expert in their own field, coming together and working for the child. That is most important in this case. Otherwise, what I would say is, though we can remove the foreign body, the oxygen level comes down to the brain. There could be brain injuries later. It is called a hypoxic brain damage, what we call. And secondly, we had another case in this COVID pandemic itself, where a child had swallowed a button battery coming from North Karnataka. Then it was severe difficulty in swallowing. They had diagnosed a button battery, but they couldn't remove it endoscopically. They came to us. Then by the time when we visualized it already, because of the alkaline material that corrodes the esophagus, it caused perforation there. After removal, it had to be again ventilated for a while. Then it had a prolonged hospital stay. So these can be definitely prevented if they come to a place where everything is available. And another case I would like to highlight again. A child was playing with some ball-like material, and suddenly child had severe abdominal pain. They came to us. We evaluated, found to have swallowed multiple magnetic balls. So that when we then after consulting and explaining to the patient that requires emergency surgery, then they operated immediately, found to have intestinal perforation, which was removed. So here the message would be: time is crucial, multidisciplinary approach, focused personnel are available under one roof. Everyone is available here. So the outcome will be excellent if they come as early as possible to our hospital.
So that those points you brought out nicely, saying that childhood trauma does not have an organ landlord. It is not a cardiac disease or a neuro disease. It is multi-organ system. You need all the specialists under one roof: emergency physicians, imaging, pediatric intensivists, pediatric surgeons, anesthetists. Everybody should be involved, including orthopedicians and neurosurgeons.
In polytrauma, we may have required for neurosurgeons, orthopedicians, all are 24 hours and everyone available in this hospital.
Yeah. So time critical injuries, they need to reach out to us as early as possible so that we are able to provide a much better outcome to the child.
Exactly.
Both intact survival is what we look at when all these children are having these issues. So Dr. Divya, if you can tell us now, for children having suffered unintentional injuries, how is our emergency room geared up? I said you are an emergency physician. Can you tell us how are we geared up and what all systems we have in place? Suppose we need to immediately address an extremely sick, critical child. What codes do we use, and how do the team come into one place as early as possible?
The first advantage, as Dr. Dhiraj told, is that our ER is 24 hours open, 365 days a year. So we have pediatricians attending the child immediately as soon as the child walks into our area. So this is a big bonus because there is no time gap between evaluation by the first person and then the pediatrician steps in. So that time gap doesn't happen. Next is our hospital's ER is very equipped to do protocol-based treatment. What they have found out in injuries is that all over the world, when you use protocol-based ATLS, that is called ATLS, Advanced Trauma Life Support. So when you use protocols, the morbidity and the long-term performance of the child is greatly improved. For example, if a child comes from a road traffic accident and this child has a fracture, so it is not only the orthopedician's work to come and do the fracture. The child has to be seen by a pediatrician, see whether the breathing is fine, the blood flow is fine. So these are the things which will determine the long-term how the child does in the long term. So a systematic approach is done in our hospital and with pediatricians who are always there in the ER. Next is, as Dr. Dhiraj told, all the super specialists under one roof with good coordination. So as multi-trauma is not one person's specialty, we have an excellent pediatric team which will take responsibility of the child and which will take help from all the super specialists. For example, calling the pediatric orthopedician, calling the neurosurgeon, calling the surgeon, calling the plastic surgeon, especially wounds on the face. Even at that moment, a good suture will prevent a scar. See, at that moment when the child is bleeding, everybody is okay with anybody suturing it. But if you have a plastic surgeon come in and suture it very nicely, that is, the parent will thank you even years later also. So having all multidisciplinary, having cooperation among them and having a strong pediatric ICU and a pediatric group to handle and coordinate everybody is the major advantage in a hospital.
Yeah, so that's great. I think you brought it out very nicely that we have a multidisciplinary team, we have a well-coordinated team, and everybody can be there on site of the child within minutes, and they can reach there and then look at, and as you told, the protocol based approach, make sure that there are enough safety nets that we don't miss anything.
Yes.
Because orthopedicians will be focusing on their own fixation but may miss a breathing issue or a circulation issue. So pediatrician is overall the team lead for a trauma scenario, but then he takes help from all these other specialists to able to kind of manage and give the best outcome for the child. So Dr. Dhiraj, many times parents will ask, what routine questions does parent ask when you advise them emergency surgery? As they will be very anxious. Such.
The first thing they ask usually is surgery necessary for the child. So I would say, unless as a surgeon, If I am convinced after all the diagnostic tools and and the child 100% requires surgery, unless without surgery the child may not do well, then only I offer surgery for the child. If there is a conservative approach and medicine approach is there, definitely that will be told to the child. If it is not necessary, we will never offer a surgical this one. And secondly, they ask next commonest question: what is the outcome of the surgery? Then we would say the earlier they come, especially I'm talking in emergency setup, the earlier they come, the earlier we handle the case, and without any other, though it is a life-threatening event, earlier we come, the outcome will be excellent. Because we have everyone, as you said, everyone working together for the child and giving the best outcome. The later they come, probably they have a prolonged morbidity. Only in polytrauma where multiple organs are involved, where there could be a poorer outcome in such. Otherwise, the earlier they come, the best outcome we get.
So, dear viewers, I think we have covered a very basic premise of child safety as such, and the idea is that children, being children, are extremely naughty. We cannot change their behavior significantly enough to prevent injuries as such. And as adults, we have to do two things. One is active supervision by looking at the child at all times and keeping them under our vision without getting too distracted. Second is passive supervision, as Dr. Divya told, that our homes, our apartments, our schools, our modes of transport, everything has to be checked on a day-to-day basis as such as to anything which is there which can put a child in harm's way. So both active and passive supervision, when we do, we will be able to prevent 90% of these injuries. So childhood injuries are preventable and predictable. So if we as adults are taking responsibility for that, we will be able to prevent these injuries in a significant way. There are few questions which have come on to as comments as well, and most of the questions are from worried parents who are worried about the current COVID pandemic. So I would request you to take those questions as well. As such, there's somebody asking these days kids are positive with COVID but are asymptomatic. How will the parent know what to do and when to get the child to the hospital? So what would you advise such a parent?
I will just put into how we are doing in our hospital. So for example, there are three scenarios. One is that a child gets fever. So this child has to come into the hospital or at least meet us in a video consult. Okay, so because in this pandemic, any fever with cough or with some tummy symptoms can be possibly COVID. So this child has to be under the radar of the pediatrician. So in the when a child gets fever with cough or without cough or whatever symptoms it is, please come to our flu clinic where this child will be assessed and the COVID testing will be done. So the other scenario is the child suddenly becomes sick. What to do? Don't panic, our ER is always open and we do take children with COVID positive also. So whenever the child is sick, you can always come into our ER and whatever time, what needs to be done will be done for the child. Third scenario is the parent is already positive, what to do. So these children should be under the eagle sign, so that we can do the testing and we can give some preventive medications like some vitamins and to boost their immunity, and then keep them under the follow-up. When they get fever, immediately escalate the medications, and if they become sick, admitting in the hospital, or if it's a very small children or at-risk children, putting them in the hospital even if they are asymptomatic. So this is how we approach a child with the problem of COVID in our hospital.
So that's very well elucidated. So we have a fever clinic where outpatient children can come with fever. We have an emergency which again has got facility to cater to likely COVID patients, where we can do an emergency blood, start the treatment, do an emergency swab, and after the report comes, we can decide where to place them inside the hospital.
Yes.
Either they go to COVID positive ward or they go to the normal ward if they turn out to be COVID negative. And we have the turnaround time for these tests around 2 to 3 hours. So that is the holding time for which the children need to be in emergency care, and then they can go to the more definitive ward as such. So also you told us about symptomatic care, multivitamins, vitamin C, maintaining, using the face mask and maintaining social distancing, regular hand wash. So a lot of parents ask us, how do we do hand wash? So I generally advise that less than 5 years, don't use hand sanitizers because they're alcohol rich and the skins are not very well mature. So use soap and water. After 5 years, you can use hand sanitizers. But even at home for COVID positive patients, we say wear masks, drink plenty of warm water, give home-based diet, and there are certain danger signs you need to watch out for, during which, if those danger signs appear, you need to come to the hospital. Persistent high-grade fever, vomiting and loose stools, some form of breathlessness, cough and cold not subsiding, other family member is more sick and is unable to take care of the child, then we will be able to cater to those populations. So again, here there are two groups of patients, one who require hospital care, and also with Aster home care having started and home isolation program having started, we have close to around 20-25 children on our home isolation care, where families are provided twice a day video consultation from the nurses, once a day video consultation from the doctors. Then there is a dietitian who advises them about the diet, and the phone helpline is available 24 hours, wherein in case the child or any family member becomes unwell and requires to come into the hospital, the ambulance services is provided on priority to these patients. So that way it's a kind of a well-knit safety system, and parents who seek out Aster as one of their healthcare destinations do not have to worry about even if they are at home. So there are a few other questions. Most of these things we have covered. The processes we have covered, and so there's Ms. Apurva asking, hello doc, my question to you is why is COVID not affecting younger children, and what is the reason? Why is this infection more in adults?
So one thing is that we still don't have published data, and we are also very nascent in this COVID scenario. Most of us have been seeing COVID cases in the last 2-3 months. See, this popular myth is there that children will not be affected, children will not get. Initially, even our government said that we didn't have any cases less than 18 years. But my message will be that children are also getting, and we have got some very sick children with COVID also. But the sad part is that we don't know which child will become sick. So we have to keep all the children under our umbrella. So the most important thing is don't panic even if your child becomes COVID positive. But the next 2 weeks, it is better to be in constant touch with your pediatrician so that the child doesn't go into that bad state.
So that's again very important. So again here with children, there are two things. One is an acute infection when they become infected and become positive. And off late we are seeing a post-COVID scenario in children, because I work in ICU. We are seeing a lot of children who had exposure to COVID 1 month back, but then they come with a kind of persistent high-grade fever, which is a manifestation of post-COVID immune dysregulation. Yes. And the cytokine storm, we call it, the immune system is causing a turbulence inside the body and attacking the body on itself. So either ways, treatment for COVID exists, both in the acute phase if they become bad, or even in the post-COVID phase when there is a immune dysregulation as such. So both groups of patients we have seen in our hospital, and we have been able to take care of them, and fortunately and luckily we have not had any poor outcome in children suffering from COVID. So in this pandemic, it's reassuring for the parents to know that children, most of them are asymptomatic, but even if they develop symptoms, or even if they develop complications of COVID, medical science has some basic knowledge right now to be able to address those problems and give good outcomes for these children as such. But that still doesn't mean that we are careless about the general routine. That means do not take your children to public places. Ensure that they are habituated to maintaining good hand hygiene. Drink warm water. Use home-based diet most of the times. Use this opportunity to cut down on a lot of junk food which children consume, because that has an effect on immune suppressant as such. And in case of any of the danger signs that are developing, seek medical care early from our fever clinic, which is open between 10 to 5, and the emergency room, which is open 24 hours. So with that happy message, I think we would come to an end of this Facebook Live today. Thank you, Dr. Divya, for your enlightening views, and thank you, Dr. Dhiraj, for telling us how the surgical world works. And thank you all for participating actively into this Facebook Live. Thank you so much.
Special thanks to Dr. Chetan
Yeah.
for guiding the entire program.